Thank you, Dr. Sweeney. Another question for you that has two parts. First of all, what was the length or time frame of this initiative? And secondly, what strategies did the Bronx Nose use to promote linkages to HIV primary care?
Well, from startup to, quote, completion, when DOH was no longer in the lead, was 4 years, 1 year for planning and 3 years of the initiative. We launched on June 27, 2008, and the official end of the initiative was June 27, 2011. And so it was a total of 4 years, including the year of planning. And so we were able to get many of our partners to be prepared, and that was part of our planning, to take over the initiative once the Department of Health was no longer involved. Linkage to care. We had workshops throughout the initiative, bringing together partners from all the different sectors, and many of the activities that we had, we matched clinical to non-clinical partners, but it ended that we didn't have to match them. They started doing this networking and self-matching. And so by the time the initiative was over, they had figured out, oh, you're very near us. We will, whenever we get a positive, and it was absolute linkage. We stopped using the word referral, because they had actually identified somebody who would be the receiver of the person that needed to be linked to care. We also are participants in the RTAS, which is, we call it RTAS, it's ARTAS, Antiretroviral Treatment Access Study, and it's a CDC DEBI, which is training on linkage to care, and all of the organizations that were involved, we engaged them in this training as well.
Thank you, Dr. Sweeney. Dr. Coe, I have another question for you. What guidelines or recommendations are currently being used for HIV testing?
Well, we are promoting the CDC guidelines for HIV testing, and those include recommending that people ages 13 to 64 be tested and be aware of their status, increased testing for people who are at risk, and then there are also new revised recommendations for people in healthcare settings as well. So these are CDC guidelines. There are, of course, other recommendations that are out there, but these are ones that we believe can increase testing awareness and meet the goals of the strategy going forward.
Thank you, Dr. Coe. Dr. Baldessari, we have another question for you. How does the HHS plan to engage youth and young adults to attain this healthy people objective?
Thank you for that question, Dr. Wright. I would say through a number of different mechanisms. First of all, let me say that in the National HIV/AIDS Strategy, a very strong case is made for the importance of continuing to educate all young people about sexual health and healthier sexual behaviors. So we're not making a distinction here between high risk, low risk, but that all young people need to understand how the virus is transmitted and how they can prevent transmission. And as probably many of the participants know, there is a specific Office of Adolescent Health within the Dr. Coe's office who deal with those issues. In addition to that, the CDC has a specific division of adolescent and school health that deals with those issues. So those are some examples of what I would say are general outreach approaches to adolescents. In addition to that, there are a number of programs that are targeted to high-risk youth. And so, for instance, Dr. Coe went through some of the statistics from CDC, and CDC indicates that when they look at estimates of new HIV infections in the United States between 2006 and 2009, the only group where they believe that the number of new infections has actually increased are are young gay and bisexual men, especially young African-American gay and bisexual men. So there are also specific prevention programs that are targeted to high-risk youth, whether those are gay-identified or questioning youth or transgender youth. So I would say there are a number of different approaches, and that just, as you know, scratches the surface. But I think that gives an example of some of the efforts underway at HHS.
Thank you, Dr. Valdesari. This questioner gets to the issue of the success of your program. Did the Bronx nose have an impact on testing or HIV testing practices in other parts of New York City or New York State? And do you know other cities or states that are replicating this initiative based on its success?
I'm very happy to answer that question because based on the success of Bronx Nose, we were ready to take on the challenge of Brooklyn. And on World AIDS Day 2010, we launched Brooklyn Nose. And Brooklyn Nose is a similar testing initiative, but the population of Brooklyn is double that of the Bronx. But in addition to that, we have expanded testing throughout New York City. And so all of our testing rates are increasing greatly. The other point is that we have been talking to other people in HIV prevention throughout the city through UCHAPS, I'll tell you in a minute what UCHAP stands for, but it's a prevention organization of the 13 major cities affected by HIV. And so we have been talking to other cities and dealing with expanded testing and talking to them about our initiative, just as Oakland did with us when we were first starting, and so forth. So yes, it's expanded, but we're doing it throughout New York City now. We have New York City Nose now. So UCHAPS is the Urban Coalition for HIV Prevention Services. And so working with the organizations that are members, we are all working together to expand testing throughout the United States in the major urban areas.
Thank you, Dr. Sweeney. I think we have time for one more question. It's directed to you as well, and I think it focuses on implementation and execution. The questioner asks, how do you propose advocating for collaboration with the existing HIV/AIDS prevention organizations? And what were your successful points for encouraging cooperation between independently run groups?
That's an important question because, as I mentioned it during the presentation, that in the Bronx there was a history of collaboration. And that really helped us get the program started and expanded in the Bronx. But the way that we have felt that it works in Brooklyn, even where it's very large healthcare system, is to bring people together. And we go straight to the tops of the organizations. So we had the Commissioner of Health, Dr. Farley, meet with the executive directors of the major organizations to get them behind the initiative. So I think that's one way to get buy-in, is to get champions in the organizations who can be supportive, and then it makes it much easier when organizations know that it's being supported from the top, and then buy-in is much easier. We also get community advocates, and we also have peer advocates for people who are supporting HIV testing. And what we do is we use data to show the need. We always support everything with data. And once the data is up there in front of you, it's hard to negate the fact that you need to do something. And so putting all those together, and we have open lines of communication, including websites specifically for the Bronx Nose Initiative, for the Brooklyn Nose Initiative, and we have the team at DOH who makes themselves completely available to all of the people participating to support them with technical assistance with whatever they need.
Thank you, Dr. Sweeney, and I'd also like to thank Dr. Coe and Dr. Valdesari for their expertise in today's panel discussion.